it all behind. Can't you see we need some time? And we all sit around the fire. We feel a little warmer now. And we all sit around the fire. We feel so much better now. And we all sit around the fire. We feel a little warmer now. And we all sit around the fire. We feel so much better now. And we all sit around the fire. We feel a little warmer now. And we all sit around the fire.
Hello, everyone. Good morning, good afternoon, and good evening. It's my absolute pleasure to welcome everyone across the globe back to today's webinar event, which is MotusAcademy's second webinar series, Summer Edition. Theme Innovation in Healthcare, Assistive Technologies for Rehabilitation. My name is Mark, and joining me as co-host for today's session, first of the 4 webinars in the series, Functional Electrical Stimulation, Deep Dive into Clinical Evidence, is Peggy.
Thank you, Mark. Hi, everyone. Peggy here. A very warm welcome to our first webinar session of the summer series. I'm very pleased to be here today to host with Mark as we hear from 3 different professionals across the world to share their perspective on functional electrical stimulation and the latest clinical findings.
Without further delay, let's welcome our speakers. Joining us on our panel today, we have Dr. Trisha, who is an Assistant Professor, Department of Rehabilitation Medicine, Division of Physical Therapy, Emory University School of Medicine, Fresno. She is also the Adjunct Assistant Professor in the School of Applied Physiology, Georgia Institute of Technology, and Director of Motion Analysis Laboratory, Center of Rehabilitation Medicine, Emory University as well. Dr. Trisha obtained her PhD in Biomechanics and Movement Science from the University of Delaware, DE, USA. Dr. Trisha's research goal is to develop novel gait rehabilitation intervention and strategies that are based on an in-depth understanding of the neuroplasticity, biomechanical, and motor learning mechanism underlying gait and gait training. Ongoing projects in Dr. Trisha's lab are investigating the time course of evaluation of changes in gait biomechanics, walking function, and cortical spinal excitability during paradigms that mimics the clinical post-stroke gait retraining, which is what she will be sharing a little bit today. And some of the tools and techniques that Dr. Trisha employs in her research include the 3D dimensional kinematic and kinetic analysis of human motion.
Next, we have Professor Milos POPOVIC, who is the tenured professor in the Institute of Biomedical Engineering at the University of Toronto. He's the director and founder of KITE, Knowledge Innovation Talent Everywhere Research Institute from Toronto Rehabilitation Institute, University Health Network. He's also a founder of Fabric-Based Research Platform and the Rehabilitation Engineering Laboratory, both located at the KITE Research Institute. Prof. Milos is a fellow of the Canadian Academy of Engineering and American Institute of Medical and Biological Engineering. In addition to this, he is also the co-founder and director of MindTech, the Center of Advancing Neurotechnological Innovation to Application, also known as CRANIA, at the University Health Network and the University of Toronto, and also Cranial Neuromodulation Institute at the University of Toronto and the Canadian Spinal Cord Injury Rehabilitation Association. Furthermore, Prof. Milos has received Inventor of the Year awards from the University of Toronto and the University of Health Networks. In 2017, he won the Accessibility Innovation Showcase and Tech Pitch Competition Award at the Ontario Centres of Excellence Discovery Conference. In 2018, Prof. Milos also received a Jonas Salk Lifetime Achievement Award for his lifetime contributions for the March of Dimes Canada. So more recently in 2019, he was awarded the Engineering Medal for Entrepreneurship from the Professional Engineers of Ontario and Ontario Society of Professional Engineers.
All right, thanks, Peggy. The last but not least, we have Professor Nazirah. Professor Dr. Nazirah, who is a consultant rehabilitation physician and director of University of Malaya Medical Center. He is also a senior lecturer at the Department of Rehabilitation Medicine Faculty of Medicine, University of Malaya. She gained her qualification in PhD from the University of Malaya University and Universities of Sydney, Masters in Rehabilitative Medicine and MBBS from University of Malaya. Her areas of expertise and interest are spinal cord injury rehabilitation, musculoskeletal rehabilitation, pressure ulcer and wound management, pain management, technology for exercise and rehabilitation, which includes functional electrical stimulation and virtual reality rehabilitation, exercise for spinal cord injury and persons with disability. Dr. Nazirah is also engaged in health promotion for persons with disability.
So now that we have a good idea of who our speakers are, let us get started. We welcome questions from the audiences, so please type them in the Q&A box below, and we'll try our very best to keep an eye on them and get our speakers to answer them live.
Okay, let's move on. First, let's welcome Dr. Trisha from Emory University of Medicine to share her presentation.
Thank you, everyone. I'm Trisha KESAR. Thank you for the nice introductions. And I will talk about some of our ongoing and more recent work on biomechanics and neural correlates of stroke gait training interventions that involve the use of functional electrical stimulation, or FES. I'll start out with the most important things because we might run out of time in the end. So I would just like to acknowledge my collaborators in my lab, without whom this work would not be possible. The population that we study in our lab is post-stroke hemiparesis. So stroke continues to be a leading cause of adult disability. And even though the prevalence of stroke is increasing and we're doing a good job with medical management of stroke, in terms of rehabilitation or restoration of function, stroke still continues to cause a lot of disability. One of the important aspects of post-stroke disability is impaired walking function. So there's a lot of biomechanical impairments. Stroke affects all phases of the gait cycle and all lower limb joints. And we see this marked asymmetry, reduced walking speed, decreased endurance, all of which are considered to be really important in terms of functional goals for people with stroke. The knowledge gap that our lab is trying to address, the most important thing to us is that there are a few interventions that are shown to improve, especially gait speed, in people with post-stroke disability. However, the mechanisms of why and how these interventions work and for whom they're most appropriate are very poorly understood. So our goal is to take advantage of, like was said in the introduction, biomechanical, motor learning, as well as neurophysiological mechanistic insights so that we can develop better interventions that involve FES and other treatments to target post-stroke deficits. So in our lab, broadly, we use biomechanical methods. So we use 3D motion capture to capture kinematics and kinetics of people with stroke gait and their interlimb differences between the affected and the unaffected leg. We also study neural correlates using non-invasive stimulation methods. So those are the two kind of techniques that we use to capture how does an individual with stroke change their walking as they go through interventions. And the two kinds of interventions we study are FES, which is what I'm going to talk about today, and also biofeedback that I'm not going to spend too much time on. So I'll talk about ongoing studies in our lab that incorporate FES to ankle muscles, and then I'll talk about neural correlates or neurophysiological mechanisms that we've studied for these interventions. So the current funded study that we have ongoing is a clinical trial that compares two interventions, FAST and FAST FES. Fast walking is actually evidence supported based on the current clinical practice guidelines for rehabilitation by the American Physical Therapy Association. So it's bilateral practice with both legs, and it involves high intensity stepping practice. And this is considered to be good for both improving walking function and also promoting recovery in people with stroke. In FES, we combine FAST, so it's dose matched and intensity matched, but in the FES group, we deliver FES to ankle muscles, ankle plantar and dorsiflexor muscles at the appropriate phase of the gait cycle. And our hypothesis is that because we're sending these stimulation signals and stimuli, sensory and motor, to these muscles of the specifically affected leg, that should upregulate lesioned corticospinal tract or CIST and motor cortex or M1 excitability. It should also, in turn, because of these neuroplastic or positive neuroplastic changes induced by the FES, it should improve propulsion and plantar flexor movement and other biomechanical variables, again, specifically in the paretic ankle. And then finally, it should improve energetics of gait as well as walking function. In contrast, FAST might induce improvements in gait function, but those should not be accompanied by these changes and positive improvements that are specific to the lesion side that's affected by the stroke and the paretic leg in terms of quality of gait. Overall, we also expect that adding FES to fast walking should improve the retention or longevity of the improvements that we see with our intervention, as well as helping us develop predictors in the long run, especially the neurophys and the biomechanical markers. So the impairment that the FES is focused on is decreased propulsion or push-off. This just shows some raw data from the affected leg, shown in green, and the unaffected leg or non-paretic leg of people with stroke. The reason we see this decreased push-off is an improper force generation or weakness of muscles on the affected leg, and also inappropriate positioning that we call a trailing limb angle. The reason push-off or decreased propulsion is important is because it's related to other biomechanical variables, such as knee flexion, but also importantly, slowed walking speed and gait asymmetry. And the way we tackle foot drop and push-off is by stimulating plantar and dorsiflexor muscles during the right phase of the gait cycle. So this just shows an overall schematic of what a training session looks like, right? FES is shown by the filled blocks, and the non-FES walking is the unfilled blocks. So we have 6-minute bouts times 5 on the treadmill. Both intervention groups practice at a fast speed, and they have dose matched intensities. However, the FES groups get intermittent 1 minute on and 1 minute off periods of practice with FES. And the FES is designed to augment motor learning, induce positive neuroplasticity, but we also don't want them to be dependent on FES. It's not designed for a neuroprosthetic. What we want to do is for it to retrain and help with the motor learning of appropriate movement patterns. This is a bigger picture, zoomed out view of the research design. So a total of 18 sessions with FAST or FAST FES. And then before and after these training sessions for both groups, we get some neuroimaging, we get some screening done in terms of exercise stress test, and then we measure biomechanics, clinical function, energy cost, as well as neurophysiology. So with this study, based on previous literature that already exists, and that's published from our lab as well as others, we're trying to supplement that and understand what's the neurophysiological and neuroplasticity mechanism of FES, and how do we identify responders versus non-responders to FES. There are certain individuals for whom FES may not be best, and FAST might be sufficient. And we want to get these data to understand that. This is just a quick example of another study from our lab where we looked at adding verbal instruction or verbal feedback to fast FES training. And the reason that's important, so the structure is very different, is because verbal feedback is heavily used in rehabilitation clinics, right? And clinicians use instructional feedback. They give information to the subject, to the participant about their walking patterns, and that promotes supposedly motor learning. What we did here was just systematically study whether adding verbalized instructions given by a neurorehabilitation physical therapy specialist, in addition to FES, promote better learning of biomechanical patterns. And quick summary, what the data showed for these 3 gait quality or biomechanical variables: push-off integral or POI, which is propulsion, trailing limb angle, which is that limb positioning, and this is ankle angle at initial contact. So ankle angle at initial contact didn't show within session or across session retention augmentation by feedback. But for the other 2 variables, when we did involve a PT or verbal instruction by a PT, we found greater learning, both within session and importantly across session, which is retention of those changes. Besides the overview of this, I also want to give quick examples of some of the more recent data from our lab that are unpublished, because we're doing a deeper dive into newer evidence. And this will be examples of the neural correlates for these FES-based treatments that we've studied. So quick overview, what we use is TMS or transcranial magnetic stimulation to study corticospinal excitability. And there are challenges with using TMS as a probe when it comes to lower extremity muscles, in contrast to upper limb muscles that have been the most of the literature has been focused on. So this is an overview of our methods. We stimulate using TMS over the primary motor cortex of the targeting the lesioned or the paretic leg muscles, ankle muscles, and we're able to record MEPs or motor evoked potentials, which are known to be affected or reduced in someone with stroke on the affected side because of decreased corticospinal drive. We also record in response to peripheral nerve stimulation. So here we're using STIM as a measure, as a measuring tool or a probe instead of as a treatment. In response to PNS, we record H reflexes, which is a measure of spinal circuit excitability. And H reflexes or spinal excitability is known to be higher or exaggerated in people with stroke. And then we use some combined stimulation approaches to measure this descending connection between the cortex and the spinal cord. So what we're trying to do is measure at multiple parts of the nervous system, cortical, spinal, and those intermediate connections, so we can get a complete understanding of how does the nervous system respond to FES-based treatments in people with stroke. So in some of our preliminary data, we did a crossover study with the same interventions, FES versus fast walking without FES. But in contrast to the details in the 18 sessions, we just did 3 sessions of training. And we looked at the neurophysiology, TMS, H reflexes, etc., before and after. And then we crossed the individuals over. The same person then went on and completed 3 sessions of the other kind of training, and we measured neurophysiology again. And with these data, these are one of the first data for the FES-based fast FES intervention on the neural correlates. So what we expected in terms of lesioned corticospinal excitability, here's just some raw MEPs. So for the FES group, when they get exposed to FES, we see an increase in the MEP, which shows increased corticospinal excitability. That's shown here with these lines on the left that show FES. Most of them are increasing, but with fast walking, we don't see that increase, and there's much more variability. This just shows the data another way. So now these blue lines are all people who increased corticospinal excitability. Fast shows much more variability. Fast FES increased both soleus, which is a plantar flexor, and TA MEPs, which is expected because we stimulated both those muscles. In terms of just summarizing other metrics, so we have TA MEPs shown here, and these dots here just show the delta, the change in that variable, fast FES minus fast, right? So if this relative change is a positive number, then fast FES has an advantage. It induces a better effect than fast. So it's an advantage to our intervention group. And for multiple variables, intracortical facilitation, soleus MEPs, TA MEPs, as well as soleus and TA MEPs collected in standing, we see preliminary data or new data that show overall all of these measures are showing positive effects or benefits with those positive numbers towards FES, favoring FES. So even if FES supposedly has similar effects in terms of walking speed as fast walking does, adding stimulation should give us neuroplasticity benefits, so that's an added advantage, as well as biomechanical benefits of promoting the more appropriate walking pattern. So the goal of quality of walking and gait speed, both improving, is accomplished by FES. And then the last thing I'll say is we're also looking at spinal circuitry, and some of the spinal or H reflex data were somewhat surprising. So these are very preliminary, and there's not as much out there with the especially plantar FES approach that we're using here. But overall, with fast FES, unlike fast, we see an increase in the H2M ratio, which is a measure of spinal circuit excitability. And we see that both with H2M max and H2M slope. So it's supported by multiple variables. And again, there's a lot of variability, but overall for fast FES, these changes induced by 3 sessions of training seem to be less up and down and much more likely to be in the positive numbers or increasing the spinal excitability. So a quick summary then of our FES research, as well as our ongoing work on the longer clinical trial. But the overall goal with this is to develop individual specific. So based on each person's neurophysiology, biomechanics, and impairments, we want to guide the precise rehabilitation according to those factors. And we want to enhance both speed, but also quality, the right movement pattern in people with stroke. And I think that is all. Thank you very much.
Thank you very much, Dr. Trisha, for sharing your insights and experience in this field. It was indeed breathtaking on learning all these things. So we now have a very clear picture to the rational and the biomechanical, as well as the neural mechanisms of FES. So this will definitely serve as a basic building blocks towards better understanding of the application of FES. So moving on, let's welcome Prof. Milos from Kite Research Institute to share his presentation on how functional electrical stimulation therapy for reaching and grasping can be used to overcome paralysis.
So thank you, Peggy, and also Mark for inviting me. And I want to thank Dr. KESAR and HASNAN for being partners in this workshop. So excellent presentation, Dr. KESAR. I really enjoyed it. So what I will talk about is upper limb. I'll talk about the mind move therapy, and I'll talk about how functional electrical stimulation can be used to restore voluntary grasping function by means of neuroplasticity. You need to know that I have a conflict of interest. I formed the company MindTech 10+ years ago, and most of these things which I'm going to present is related to the product that a company is producing. What is relevant for you to know is all the results in science that has been done before the company has actually been formed. So before we actually thought of creating the enterprise. So functional electrical stimulation, you probably all know what it is. It's you provide electrical stimulation to different muscles, and if you coordinate them properly and time them in the right way, and you control the force of the muscle contraction, you can get very nice reaching, grasping, and complex movements that we perform every day. So going forward, so how does a functional electrical stimulation work as a therapeutic tool? And we discovered that over 20 years journey. I have chosen a stroke example. So if you have a patient who had a stroke and you ask the patient to perform very specific movement, the patient can imagine that movement or can work on that, but they're not able to actually send the command, to the spinal cord and the muscle to actually generate the function. What we do is, while patient is striving to do a complex movement like touching the nose, and they're trying to do that without being able to move the hand at all, you fire all the muscles responsible for the movement that you want patient to perform. And as the movement is executed, the muscle spindles and other proprioceptive information is fired back to the spinal cord and the upper layers of central nervous system. In doing this repetitively, you create completely new pathway for sending a command from the upper levels of central nervous system to control the muscle and control it voluntarily. So functional electrical stimulation that we are using has about 35, almost 40 different protocols. These are different position of the muscles that we are firing. So biceps, pectoralis major, serratus, even lower trapezius, especially for reaching forward. This is for extensors. This is for finger flexors. And we also do intrinsic muscles. So you can do tripod grasp or pinch grasp and things like that. With a system, which is an 8-channel system, you can actually execute very complex movements like reaching forward and hand opening. Hand opening in stroke patients is a very complicated thing to do. So we have proprietary technology that allows you to really nicely fan the fingers. You can also do the tripod grasp, lumbrical grasp, key grasp. You can do it even by manual for spinal cord injury patients because both hands are affected. You want them to pick an object with one hand, bring it to the other hand, pick up the object, release from with the first hand, and move it to another target, or picking up the tray or some more complex objects that require bimanual operation. We even have the protocols that do that. This is how the device looks like. It's called MindTech. MindMove. It's produced by company MindTech. Has, as I told you, almost 40 protocols. And they're divided into different groups. You have protocols specifically targeted at stroke patients, which are really working hard on finger extensions and opening, because that's more challenging for stroke patients. And for spinal cord injury patients, you're more focusing on flexion, closing the hand, reaching the mouth with the hand and things like that. I'm going to show you one of the most complex protocols that we have. The patient that you're seeing, there's a patient who is receiving it for the first time. This is amateurish done video, but it shows you how that looks like on a day one with the patient who is 5-6 years post-stroke, and he's not able to move the hand at all. So all the movements that you're going to see are executed by electrical stimulation. And what a therapist is doing, she's targeting or timing every single phase of the movement, and it's guiding the hand to execute the task. Why she needs to guide the hand? Because functional electrical stimulation is not very precise in controlling the exact angle of the muscle, of the limb. So you need the therapist to make sure that the proper extension is executed in the proper direction, things like that. So what patient is trying to do is activate the biceps, extend the arm, extend the elbow, and open the hand at the end. So this is happening very slow because it's his first time that he's doing that after 5-6 years. And it's very slow in this phase. And you will see now she's going to ask him to open the fingers. His fingers are typically flexed like a typical stroke patient. And now she's going to fire electrical stimulation.
And you'll see how the fingers open and fan nicely.
Just be patient for a second. What is important is in the beginning, when you start working with the patient, it takes time for the patient to execute the task, especially complex tasks like this. However, as they work with you day in, day out, they're able to do more of these tasks within the unit of time. So we typically have 6 or 7 different protocols that they're working on during single working session, which is almost an hour. And what happens is that at the beginning, they'll do 2 or 3 reaching sideways and opening hand on a session 1. On session 5, they can do 7 or 8 or 10 or whatnot. And normally we start working with proximal muscles first and joints and moving to distal. And at the end, you do finger flexion, extension, and all these things. Okay. The key element here is because a lot of people in a rehab universe are trying to move the therapist out of the equation. We feel very strongly the therapist is a critical element in the process. So we train therapists really well. They guide and time the protocol and the quality of movement. They choose themselves which are the right protocol for which patient at what time in their recovery. The patient is also very important. Patient has to participate. If the patient is not cognitively there, and is not watching what's going on, and is not trying to do what you're instructing them to do, this is not going to work. And of course, you need to have a FES device that can really accurately and nicely generate the movements that you want to have. We have a little trick that I didn't advertise. The stimulator that we have produces electrical pulses, which are patented, and they are less uncomfortable and less painful, and that enables you to work with even with children and stuff like that. So I'm just going to show you the patient videos before and after. And if you want to find more on all the papers and journal papers, I'll give you where you can find them for free. So this is a stroke patient who had all possible therapies, even amphetamine and whatnot, for 9-10 months. And this is his status after about 10 months of therapy. So he's not able to open the fingers, he's not able to grasp an object, and that's it. The therapy works equally well with young people and old people, so don't be fooled that we have a younger individual that they're doing better. No, that has nothing to do with it. Where it doesn't work, if the patient is not paying attention. If patient is not involved, the therapy doesn't work. So this is the patient before, and you will see what he's able to do on his own without electrical stimulation after 40 hours of treatment. So no electrical stimulation, is just him, his hand, and what he's able to do. I want to show you another one. This is a spinal cord injury patient. This is before. Both of these tasks are part of the Toronto Rehab Hand Function Test. So what they have to do, this test is very challenging for spinal cord injury patients because they have to open a hand and they have to grasp the sponge. And because sponge is giving in, they have to control the force in order to be able to lift and manipulate object going into supination, pronation, and whatnot. And you see at the beginning, she's not able to do that. So that's a baseline assessment. And this is what she's able to do after 40 sessions. At the bottom is the journal paper where this is published in 2011. It's neurorehabilitation, new repair. Now you can see here she's going into supination, and she'll bring it back into pronation and put it on a table. What is exciting about the therapy is once they get the function back, they don't decline. They can continue improving if they start using in activities of daily living, which normally when you are able to use your hand, you do. You feed yourself, you hold things, you manipulate things, but we have never seen a decline, which is very important. Conclusion, it's non-invasive neuromodulation intervention. It can be delivered in a variety of settings. So the device actually will allow you to deliver it at home, but you need the therapist there to deliver it, or occupational therapist, physiotherapist or occupational therapist. The patient has to be mentally engaged. The therapy is quite repetitive. You're doing things over and over again, same things, for 5 minutes and another thing for another 5 minutes. And recommended dose is minimum 40 hours. We had patients who went up to 120 hours of therapy, especially patients who were 15, 20, 30 years after stroke. Again, it has to be in combination with the physiotherapy, occupational therapy, and the therapy restores voluntary upper limb function. When you finish the treatment, you can take the device away, and the patient should be able to do the task on their own. These are all the people who funded our research over a very long period of time. Special thanks goes to Dean Connor and Mari Suffelman and Maria and Walter Schroeder for their donations. And all the papers came, and videos and all these things can be found on this webpage. And if you want to see what we're doing, you can follow me on Twitter. And this is the organization that pays my bills. Thank you.
All right. Thank you, Professor Milos. That's definitely been very informative. And in the world of all occupational therapists and physical therapists, even rehab doctors, we all know like upper limb rehabilitation is definitely one of the so-called nightmares that we all come through for years and years, that things, can't improve. There's a lot of blocks along the way. All right. Yeah. So it's great to see how the FES for reaching can be used to overcome paralysis in this slide. Thank Professor Milos. So let's move on to finally introduce and welcome Professor Nazirah to share her presentation on FES exercises after spinal cord injury. I hand over to you, Prof. Nazirah. I believe your mic is, you need to switch on your mic, Prof. Nazirah.
Yeah, okay. Thank you very much, Mark. Good morning, everyone. Good morning from Malaysia. Really enjoyed the talks by Dr. KESAR and Dr. POPOVIC. Dr. POPOVIC, mind-blowing presentation as usual. Dr. KESAR, I learned so much from your presentation and updated presentation today. I'll be talking on the exercise aspect of FES, and that's the area of interest that I have, which is to prescribe exercise for people's spinal cord injury and using functional electrical stimulation. And I hope this will come up for everyone to see. It's taking a bit longer than usual. Okay, are we good? Yeah, so people who work with spinal cord injury know that there are restrictions in the performance of physical activities and social participation in this group of people, and it has got a profound effect on fitness, exercise capacities, and health. And as a result, there is a greater risk of cardiovascular disease compared to the general population. And people with spinal cord injury are at risk of secondary conditions and multiple complications. And it's a vicious cycle between these issues as well as health and fitness issues. And there is evidence that shows that exercise is a cornerstone for spinal cord injury rehabilitation. Regular physical activity exercise provides important health benefits by improving cardiovascular fitness, muscle fitness, mobility, improve ability to do ADL tasks as shown by Dr. POPOVIC earlier, and overall improvement in mental health. And exercise helps to prevent spinal cord injury related complications and secondary conditions, and enhances community reintegration and participation, which is the overall goal in rehabilitation, not just for spinal cord injury, but for all our clinical populations. So how do we prescribe exercise? What do we prescribe? How much, and where? And I've struggled with this for a long, long time. What do I prescribe my patients? And what do my patients, how do my patients exercise? So there are various exercises that can be prescribed. And the physical activity guidelines prescribe a combination of aerobic and strength training exercises. But what kind of aerobic exercise? What kind of exercises can be prescribed? And I used to prescribe upper body exercises, and I tell my patients, yeah, you will more. Do more wheeling, and that's exercise for you. But we now know that upper body exercises through wheeling or arm cycling or any of the upper limb sports only elicits small increases in maximal aerobic power. Oxygen uptake is about 30% less than oxygen uptake during less leg exercises in non-paralyzed limbs, or can even be more than that. And it has been found that and shown that arm exercise capacity is limited. And this is because of compromised venous return, which results in reduced cardiac output. And there is insufficient blood flow to exercising muscles because of the small muscle capacity in the upper limbs. And this results in this situation called circulatory hypokinesis, where the cardiac output, which is much lower than the given VO2 that's produced through upper limb exercises. And through upper limb exercises, this unique cardiovascular adaptations through reduced ventricular filling, reduced stroke volume, cardiac output, increased total peripheral resistance, heart rate, and blood pressure, which is not an optimal situation for aerobic exercises. So basically, in upper body exercises, it's physically demanding, arm exercise capacity is limited, and there's also potential overuse of injuries in upper extremities. So we know that we need to prescribe lower limb exercises in spinal cord injury, but this is a difficult task, as we can imagine, because it's difficult to train paralyzed limbs. There's loss of ability to contract lower limb muscles independently. So these lower limb muscles need to be evoked artificially. There's also smaller major skeletal muscle cross-sectional area over time, and it has been shown that deconditioning, muscle wasting sets in very early after acute spinal cord injury. And there's changes in muscle quality below level of injury as well. And this overall, there's limitations in cardiorespiratory response and exercise performance. So with FES, we are able to evoke muscle contraction. So paralyzed muscles can be artificially evoked to produce dynamic movements, as shown by Dr. POPOVIC earlier. The active leg muscle contractions via FES application can augment blood flow, can improve leg edema, will activate the skeletal muscle pump, and by doing this, will increase venous return. And this leads to enhancement of cardiorespiratory response with increased oxygen uptake, heart rate, stroke volume, cardiac output, which is the optimal exercise responses. And lower limb exercises can be done through cycling, stepping and walking, body weight supported treadmill walking, and FES assistance can be incorporated into all these exercises. So these are the various types of FES leg exercise. And in the earlier studies, the use of FES was to overcome paralysis. But in the recent developments, over time, it has been shown that FES is very, very beneficial to enhance clinical benefits through exercises. And evidence shows that improved cardiorespiratory fitness through FES, improved cardiovascular conditioning through improvements in cardiac function and structure. It has been shown to increase left ventricular mass and cardiac output, reduce arterial stiffness, improve endothelial function, and overall improve systemic inflammation, improve lipid profile by raising serum HDL, and improvements in body composition, improvement in glucose metabolism. And this overall effect has got the potential for cardiometabolic protection. So it's not just about improvement of fitness, it's about improvement of cardiometabolic functions, prolonging life, and reducing cardiovascular complications. So we've talked about upper limb exercise, lower limb exercise, but what we are promoting is a whole body exercise concept using the hybrid arm and leg FES cycling. And it has been found that through the arm and FES leg exercise or the hybrid exercise, it provides better whole body exercise benefits as it facilitates activation of a larger muscle mass, enhancing aerobic performance and capacity, producing higher cardiac outputs and oxygen uptakes. And in the study which I've done, 6 weeks of hybrid in the high interval intensity training, improve peak exercise performance, aerobic fitness, leg girth and volumes, and HDL in persons with chronic SCI, and therefore providing optimal levels of metabolic and cardiopulmonary responses for aerobic conditioning and whole body training. And this some videos of showing the difference in cycling as well as arm and leg cycling, and combined arm and leg exercise develops a higher oxygen uptake and greater cardiovascular demand compared to arm cycling exercises or leg cycling exercises alone. And what we have also done was we've incorporated virtual reality into this hybrid FES cycling by using the outdoor FES bike, which can be used indoor as well by connecting it to a virtual reality system. What we've done was we've videotaped the outdoor environment, incorporated into a virtual reality program. And what we have found is that there's no difference in the cardiorespiratory responses between indoor and outdoor arm and leg FES cycling. So combining FES technology and virtual reality technology may provide new opportunities for physical activity motion for exercise rehabilitation in the spinal cord injury population. And this is a short video of—
Hi everyone, I'm Yohanis from Malaysia. When I first introduced to FES when I visited Prof. Nazirah at the Feasibility Center at the University of Sydney. I was in Melbourne at the time. I love it. Then when we both back in Malaysia, so I joined a research project for 6 weeks, and the session is about 3 times a week. And during that duration of doing FES, I've increased my circumference of my thigh for about 3 centimeters. That was great. Yeah, ever since that, I've been volunteered and recruited as participants for any of the FES project conducted by University of Malaya. Yeah, it is great. I mean, I've benefited a lot from it, not just a fitness level, as well as the well-being. The only wish is that, because everything is done in a laboratory setting, so I wish that FES can be made available for other people make it like readily available, make it portable, so that people can use it at any time outdoor instead of having in lab setting. And I have done both the hybrid and also the rehab bicycle, and I've enjoyed more of the hybrid where you use your arms and your legs at the same time, because that will actually give you more benefit rather than just passive cycle.
Thank you very much, Johannes. So that's, I thought I would like to share that with all of you, experienced by one of our subjects. And in the year 2021 itself, there were 3 systematic reviews which look into the outcomes of FES exercises. And it has been shown through one of the systematic review, which look at the outcomes on fitness related outcomes, that FES cycling improves lower limb muscle health through larger muscle volume, shift to more fatigue resistant fibers, and FES cycling may increase power output through improved peak power and oxygen uptake during FES cycling tests. And in another qualitative review, has shown that there is cardioprotective effect of exercise using FES, and that another systematic review by Goge and group has shown that concluded that FES is an effective rehabilitation strategy, result which shows muscle hypertrophy and increasing lean muscle mass. And for FES in spinal cord injury rehabilitation, there are various other applications other than health and fitness applications. And as we have heard from Dr. POPOVIC and Dr. KESAR as well, there are many other applications. And for a successful clinical application of FES, Dr. POPOVIC has described it really well. It's got to be goal-specific, outcome-oriented. It's got to be integrated into an MDT rehab program. It's not a standalone intervention. We must identify patients correctly. Patient needs to be educated on the FES, and also the expectations needs to be managed. Tolerance of current should be paid attention to, and of course availability of device for regular use. Currently, the evidence does not provide us prescription for a minimum or optimal dose of FES cycling exercise, and what neuromuscular stimulation characteristics are to be used to optimize outcome, and more research needs to be done in this area. Future directions is definitely on optimizing optimizing the FES to delay muscle fatigue and improve muscle endurance, because fatigue is still an issue because of the artificial recruitment of the muscle fibers. We need to look at technology that allows high intensity training, because it has been shown that high intensity training providing high VO2 is the key to providing health fitness outcomes. We need to use digitalized platform and social networking to improve adherence to exercise, better signal control technology. Future direction should be looking into brain control interface for FES, and a multifunctional network device, hopefully one device for all. And I think this is something that is with great potential, and we're able to achieve this, which is to incorporate FES into technology for a spinal cord injury rehabilitation exercise. I've shown you that we can incorporate virtual reality and FES together, and we can definitely incorporate FES into exoskeleton, robotic, and all movement therapies as shown by Dr. POPOVIC. And activity-based therapy can be definitely augmented by using FES. So with that, I say thank you.
Right. Thanks, Prof. Nazirah. I got to say, the whole body cycling looks really fun together with the FES.
It is.
Someday I got to try it to see how it works.
Come to my lab.
Yes, definitely. So thanks again to all our speakers for sharing. And thank you to our audience for the time and attention. Now we are open to questions, and we've got a lot of questions in the box already. And thank you, Dr. Trisha and Prof. Milos, for answering some of them. But let's just break it down, and let's hear Dr. Trisha on the first question that we've actually had. So anonymous attendee asked, does FES therapy incur a great cost on patients' energy level, and what can be done to help elevate this? So let's start with Dr. Trisha, and we'll see if our Prof. Nazirah and Dr. Milos has anything to add on it. Yeah, all right.
Sure, yeah. So I gave a quick summary of previous research. So there's a published study on the FES approach that I use, which is plantar and dorsiflexor FES combined. And the one study after 24 sessions of training, so over multiple training sessions, actually showed improved energy cost and improved long distance walking function for the FES group as opposed to the non-FES group. In our study, we're interested in, we expect that energy cost will improve, and we are expecting or predicting that it'll improve because FES promotes more symmetrical walking patterns, and those symmetrical biomechanical patterns incur less energy use. So in the long term, with multiple sessions, we actually think it should improve energy cost, and some of the ongoing data hopefully will support that. We don't know yet. But I think in the short term, and Dr. POPOVIC and HASNAN can comment on this as well, in the short term, as someone is getting used to FES, in the first few training sessions, there's a familiarization period, and temporarily, as they're adjusting to it, their energy cost might, worsen. But if you continue with FES over multiple sessions, we definitely see more smoothness or coordination patterns improve, and their comfort or their sort of ability to walk and use their muscle drive, voluntary drive along with FES also improves. But I do agree that's a good question, and more studies should be done on that. More systematically, we should evaluate both the effects of energy cost and how does the intervention or FES change energy cost.
Any input from Prof. Nazirah and Dr. Milos himself?
Lunch.
No, I totally agree with Trisha. The only thing which I would like to, I think we spend a lot of time worrying about energy cost. Really, the function is what patient craves, and if they can do something functionally that they couldn't do before, it's a huge deal, and they're willing to deal with some of those energy issues. One thing which is important with locomotion, which is not really a problem with upper limb, is that you need to have certain muscle strength and capacity in order to walk. So if you, as Trisha, takes the patients and gets them and they improve and they're doing really well, and now they're walking with a walker, without a walker, whatever arrangement they have. If they now get a pneumonia, for example, or they get sick and they end up in the bed, and they're in the bed for a week or 2 weeks, they decondition. So when they want to go back to walking, they may run into challenges that are just purely physical, muscle strength. They lose muscle volume within these 2 or 3 weeks. So for patients who got into gait as a result of FES, and whenever they have this type of events, which they have, we all have it, right? They may need to go back to Trisha to get through some maintenance regimen or some strengthening, muscle strengthening, to get them back on their feet so they can go back and transfer and walk and whatnot. I think this is very important. We don't talk much about it, but this is the reality. With upper limb, this is not a problem, because even if you lose quite a bit of a muscle volume, it's good enough to lift things against gravity. And as soon as you start going cooking and doing things, you go back into the normal regimen of working. But standing and walking, they're not only energy demanding, but they're also, you need to have a muscle strength to do it. And there are many things that can compromise that. I hope you agree with me, Trisha and Nazirah.
Yeah, no, I agree, especially about the conditioning, the strength and conditioning, and FES having that unique ability to restore that, unlike, for example, passive orthotic devices.
Yeah.
Dr. Hassan, you want to say something?
I totally agree with both of you, and as mentioned in my talk, that with FES you are able to improve lean muscle mass, and you get muscle hypertrophy, and this will definitely help with muscle strengthening and improving the gait functions. Yeah.
I have one comment, unsolicited, but I think it's very important. When you first time provide electrical stimulation to the patient and you're expecting particular response, you may not get it.
Yeah.
And even if you stimulate the fingers, you may not get the hand to close nicely. You may get this, right? And you get frustrated, especially spinal cord injury. You get really frustrated with that. Don't get distracted by that, because in a session 3, all 4 fingers will come in, or session 2 or session 5. So just keep on doing what you've been told and trained, and within a day or 2, as the patient's muscles get stronger and they get accustomed to what electrical stimulation is all about, they will do way better. And also they get accustomed to some discomfort, because not all stimulators are painless or have low pain, induce low pain. So they need a couple of days to realize that this is not really a pain, it's just discomfort. They get used to it, and then after that, off they go, and they can do wonderful things with that.
Right. Thank you so much for the comments. I think it kind of links to the questions that was for Prof. Milos. So there's this question here, given the FES therapy is often very slow. So how do we actually reach sufficient intensity of the training to induce neuroplasticity? And what is the average number of movement repetitions for an hour session?
So the therapy is slow. So therapy has to be the slow on a day 1, because the patient has tone, they have spasticity, the muscles are, behaving funny. The central nervous system has been fundamentally disconnected from the muscles. They have high gain in the spinal cord, and all of a sudden the patient has tone in all the muscles. So if you measure EMG on all the muscles in the arm or the leg, they're all up. So when you start FES to reach and grasp, you're actually fighting the other muscles which should be relaxed in the moment when you're extending. So your biceps is contracting while you're trying to extend the arm. But when you do it 4 or 5 times, all of a sudden, and we have papers published on that, so I'm happy to share this with you, all of a sudden the tone in the system drops down. So the patient who came like this, after 3 reaching tasks or 5, the hand comes down. So what is exciting about it, once the hand becomes more relaxed, you can get more repetitions out of that. So the first time you're reaching or grasping is pain in the butt, I'm sorry. But the second time, third time, you start getting more range of the motion, you get more of the muscle strength, and of course they get tired in the first session. In the second session, you still have these problems, but they start decreasing much faster. In the session 6, you don't have a tone in the system at all, or it's marginal. And then you can do 10 repetitions like this, right? And the thing is, what is important is not how many repetitions you have, it's how many times the patient is trying to do that voluntarily. If they try to do it 2 times actively, that's valuable. If you do it 55 times, sorry, I'm going to talk about Bioness 300. You can do this with Bioness 5 million times. Value of that is 0. The value is if the patient is trying to open the hand and they struggle, and then you fire all the muscles and the hand does that, bingo, that makes a difference. But this with Bioness is doing nothing for the patient. And we have papers to prove it. So it is not in repetition, it is in a meaningful, focused, and patient is actively engaged that, and then you have repetition, bingo. It's like playing baseball, right? First time you do it really bad, the more you're focused, the better you are. Same.
Sure,
Sorry,
that is very, no problem. That is very interesting to know that. How about Prof. Nazirah? Do you have any comments to add on to that question?
Sorry, so this is...
anything to add on to what Prof. Milos have mentioned?
Prof. Milos has described it in, I think I can't add anything more except that, the activity has got to be purposeful, and
Right.
And that is very, very important, and to get the patient to be an active participant is another important factor here.
Right. Yep. Thanks, Prof. Milos and Prof. Nazirah. And yeah, probably that brings us down to an anonymous attendee asking Prof. Nazirah whether this then has the comparison between the exercise programs such as robotic training and automatic exercises for spinal cord injury patients.
Yeah, so it's a very interesting question and a very important one, because I get asked that a lot, and not just by patients but by therapists as well. Why can't we just allow passive cycling, and why do we have to incorporate FES into the passive cycling? Why can't we just use exoskeleton and get the patients to walk using a robotic device? And why do we want to incorporate FES? And as we have heard, FES is about evoking muscle contractions. And by evoking muscle contractions, we're able to strengthen muscles. We're able to improve muscle mass. We are able to stimulate a cardiovascular response. Unlike in passive cycling, unlike in robotic walking, where it is basically a passive walking, because it's a robotic movement without any stimulation of the muscles involved in walking. So in my lab, what we are trying to do currently is we're trying to incorporate FES into an exoskeleton device so that we can, so I'm a great believer of, incorporating technologies together and optimizing what we can achieve from various technologies. So by incorporating FES into an exoskeleton device, what we're able to do is not just gait training, but also to strengthen the muscles by using muscle contraction to initiate the walking. And as the patient becomes tired, as the muscle becomes fatigued, then the robotic exoskeleton can take over the functions. I believe that this is something that we must work on, to incorporate muscle stimulation, muscle contraction into the technology which allows only passive cycling, only passive walking. Yeah. So that's the difference.
Right. Thank you so much, Prof. Nazirah, for addressing these challenging questions. So do we have any more comments to add on? If not, because I think we are kind of running a little bit out of time. So I would like to take this opportunity to thank everyone, thanks the panelists to joining us, as well as today's webinar. So now, if you can see in the screen, we would like to bring your attention to the poster presentation. So if you can see on your left-hand side, this is the poster for the next webinar. So this will be held on the 26th of May, which is next week, with the topic of telerehabilitation, an innovative model for community care. So this link registration is provided in the chat box if you can click on it. And on your right, we have this QR code that leads you to the feedback form, where you will also find a section to fill up your name for the certificate. So this will also be issued for your participation. And we really appreciate your time and effort to fill this feedback form. So for now, I would like to thank you again for participating this webinar, as well as all our speakers here. Is a very interesting topic that we are talking about. So we look forward for more informative, more clinical evidence to help the public there. So for now, goodbye, stay safe, and we look forward to seeing all of you next week.
Thank you,
Thank you,
everyone.
Peggy and Mark.
Thank you.
Thanks, everyone.
Yeah.
Thanks. Bye-bye.
Have a good day.
Bye-bye. Have a good day, everyone.
We found our place on the branch of an old gum tree. Our feet would sway to a voice in the